Comparative colorectal cancer risk between angiotensin-converting enzyme inhibitors and angiotensin receptor blockers. This is a propensity score matched population-based study with competing risk analyses. I am Joshua Fung, and this was a study that I conducted as part of my GPS project under the guidance of Professor Gary Tse. So my involvement in this study primarily involved, as a first author, data acquisition, the interpretation of this data, the analysis of this data, the drafting of the manuscript, as well as final critical revision of the manuscript for submission. So a bit of background about the study. So renin-angiotensin system blockers, which we know to include conventionally angiotensin-converting enzyme inhibitors, or ACEIs, as well as angiotensin receptor blockers, ARBs, are some very commonly prescribed medications in the healthcare setting, particularly in the treatment of hypertension. And in fact, ACEIs are now very much considered the first-line antihypertensives for chronic control. Now, recent studies of note have actually reported some association between the use of ACEIs and a potential risk of malignancy in cancer. And the most notable of these may be this study published by Hicks et al. In 2018 in the BMJ, which actually showed that ACEI use was associated with higher risks of lung cancer compared to ARB use. Now, the existing literature on cancer risks from the use of ACEIs are mixed, and they very much lack a consensus, in that there are some studies, such as the one above, that show some association with increased risks of lung cancer in the use of ACEIs compared to other antihypertensives, including ARBs, diuretics, and calcium channel blockers. But there have also been studies that actually show a protective effect on malignancy when it comes to the use of ACEIs, as well as studies that show no association. And so this is an area that requires further study. And so the objective of our study was really to compare the risk of colorectal cancer between the use of ACEIs and ARBs. And in order to do this effectively, we used a propensity score matching approach to assess this association of the use of these drugs and the incidence or risk of colorectal cancer. Now, for our methodology, this was a retrospective population-based cohort study that we identified using the Clinical Data Analysis and Reporting System, otherwise known as CDARS, which is a database that covers the entire Hong Kong, and all the public hospitals and clinics and ambulatory care facilities that are under the administration of the Hospital Authority. And the included cohort was collected through the inclusion criteria of all patients that were prescribed ACEIs or ARBs during our study period, which was the 1st of January 2000 to the 31st of August in 2020. And the exclusion criteria was the patients that were prescribed both ACEIs and ARBs during that study period, as well as patients that had a diagnosis of colorectal cancer before the first prescription of ACEIs or ARBs. Now, our included cohort was comprised of more than 400,000 patients with 355,000 ACEI users and 55,000+ ARB users. And from this included cohort, we produced a propensity score matching and a 1:2 ratio in order to generate the matched cohort, the matched control cohort that numbered more than 168,000 patients. And this is the main procedures in terms of the development of the matched control cohort that I illustrated earlier, and that we gathered 500,000 patients that used either ACEIs or ARBs or both from CDARS during the study period. We excluded those that used both ACEIs or ARBs, as well as patients with a baseline colorectal cancer. And From there, we got our included cohort of more than 400,000 patients. And we then did propensity score matching in order to obtain our matched control cohort. And our propensity score matching we did based on demographics, Charlson score, a CHADVAS score, past comorbidities, as well as other medications. All of this information was gathered from CDARS and was readily available from CDARS. For our statistical analysis, we first did Kaplan-Meier survival as well as univariate Cox regression models to evaluate the significant prognostic risk factors as well as the exposure effects of ACEIs or ARBs on the incidence of new onset colorectal cancer. We did the same for other outcomes, including all-cause mortality and cardiovascular mortality. We then did a competing risk analysis for cardiovascular mortality and non-cardiovascular mortality via cause-specific hazard models and subdistribution hazard models. And we reported hazard ratios with corresponding 95% confidence intervals and p-values. And we used two-tailed significance tests to determine statistical significance, with p-values of 0.05 considered significant. Now, our results indicated that there was an incidence rate of colorectal cancer in patients with ACEI use was actually higher than that of ARB use, both before and after the 1 to 2 propensity score matching. In that, ACEI use was associated with incidence rate of 1.95% compared to 1.17% in ARB use. We then did univariate Cox models, which identified the risk factors of new onset colorectal cancer, and that included male gender, older baseline age, larger carcinoma comorbidity, higher CHADVAS score, prior hypertension, COPD, gastrointestinal bleeding, and baseline cancers other than non-colorectal cancer. These were all found to be risk predictors of new onset colorectal cancer. And for our Kaplan-Meier survival curves of the new onset of colorectal cancer, we found that after propensity score matching, and actually even before propensity score matching, ARB use was associated with lower rates of new onset colorectal cancer compared to ACEI. That was a hazard ratio of 0.81. Likewise, for all-cause mortality, the Kaplan-Meier survival curves show that ARB use was associated with lower rates compared to ACEI. And in terms of our univariate Cox models done for all-cause mortality, we found that actually ACEI drugs, the most notably we know of lisinopril, captopril, were actually associated with higher risks of all-cause mortality, whilst ARB drugs such as losartan were associated with lower risks of all-cause mortality. And for cardiovascular mortality, we found that Kaplan-Meier survival curves found, again, ARB use was associated with lower rates compared to ACEI. So we found that for all three of our outcomes, including new onset colorectal cancer, all-cause mortality, and cardiovascular mortality, ARB use was associated with lower rates of all these outcomes compared to ACEI. And again, for our univariate Cox models, to evaluate risk predictors of cardiovascular mortality, we found that ARB drugs were actually significant protective for cardiovascular mortality compared to that of ACEI drugs. And for our competing risk analysis, the cumulative incidence of all three of our outcomes, including new onset colorectal cancer, all-cause mortality, and cardiovascular mortality, again found that ARB was associated with low cumulative incidence compared to ACEI use. And so our main findings was that compared to ACEI users, ARB users had lower risks of new onset colorectal cancer. And this observation was found both before propensity score matching and after propensity score matching. And the difference is quite significant. It's 19% after propensity score matching. And we also found that ARB use was also associated with lower risks of our other two outcomes, all-cause and cardiovascular mortality, compared to that of ACEI users. And then these three findings, the lower risk of all three of these outcomes in ARB users compared to ACEI users, was confirmed in the competing risk analysis shown from our cumulative incidence. So the strengths of the study is that It's a population-based study, and we collected data from the CDARS database, which covers all public hospitals and clinics under the hospital authority. And so it is territory-wide and therefore widely representative of the Hong Kong population and covers all geographic and demographics. Additionally, the study cohort involved more than 400,000 patients, which is actually the largest cohort of ACEI or ARB users that has been used to investigate colorectal cancer incidences and compare the association of ACEI and ARB with malignancy. Notably, it is larger than the cohort used in the BMJ study that I referenced in the background. And another strength of this study is that there was a very long follow-up period of almost 20 years, more than 20 years. But there are also some limitations in that this study relied on administrative coding because it gathered data from a database. And it's important to note that this database does not include information about smoking or diet habits and body mass index, which are not regularly or routinely coded into the database. And so we could not consider these variables, which may well be risk predictors and may well influence the propensity score matching. But we were unable to gather that information, and therefore they were not included as risk variables. Similarly, this study cannot consider the effect of drug non-compliance among patients, and that may result in some misclassification. It must be noted, however, that rates of non-compliance should be similar, or at least comparable, between the ACEI and ARB groups, and therefore there should not be a statistically significant impact of drug non-compliance on the comparative risk analysis of ACEI and ARB users. Thank you.